Good evening, everyone. I am Olaoluwa Ezekiel Dada. I am a medical student from the University of Ibadan, Nigeria. I'm also a member of the operation department at AFAN. I'm glad to have you all once again to today's webinar in continuation of the Neuro Oncology course presentation. So I would like each and every one of us to present ourselves, and I'll actually call on you guys to present yourself. Dr. Daniel, please, can you unmute yourself and present yourself?
Hello, everyone. Good evening, everyone. I'm Dr. Daniel Safari from Democratic Republic of Congo. I'm actually a research assistant at the Forensic Center at Official University of Bukavu. I'm equally an AFAN research fellow and an assistant in the Department of Surgery at University Clinics of Bukavu. I'm glad to be with you this evening.
Oh, thank you, Dr. Daniel. Okay, next, Leslie Jogo, please unmute and present yourself.
Good afternoon. I'm Leslie Jogo, fourth year medical student in FMBS of Garoua, and I'm very happy to be here.
Thank you, Leslie. Next, Aris, unmute yourself and present yourself. Ziso Aris.
Hi, good afternoon, everybody. Zishu Harris, a third year medical student from Cameroon.
Thank you. You're welcome, Aris. Next, Samuel, unmute yourself and present yourself.
Good afternoon, everyone. My name is Samuel. I'm a medical student from Obafemi Awolowo University, Nigeria. It's a privilege to be here this afternoon. Thank you.
Oh, thank you, Samuel. Next, Iberi, can you unmute yourself and present yourself?
Hi, good evening, everyone. I'm Chidi Iberi, and I'm a medical illustrator from Nigeria. It's good to be here today.
Thank you, Iberi. You're welcome. Next, Zolo, unmute and present yourself.
Thank you very much, Ezekiel. My name is Zolo. I'm a final year medical student from Cameroon. I'm also the president of the Association of Future African Neurosurgeons. It's a pleasure to have you all tonight. Thank you.
Yeah, thank you, Zolo. Dr. Ikwuegbuenyi Chibuikem, you can unmute and present yourself and go ahead with the presentation.
Hi, everyone. Chibuikem Ikwuegbuenyi, MBBS Lagos, and I'll be taking us through the fourth oncology series today. Just give me a moment. Right. Can everyone see my screen?
Yes.
Yeah.
All right, great. So, so we're continuing the Neuro Oncology course. Today we'll be having the fourth case. I'm Chibuikem Ikwuegbuenyi once again, MBBS Lagos, Nigeria. So we're going to go, the presentation is going to be divided into two parts. First, we're going to discuss the case, and then second part, we're going to discuss the literature on the topic of today's case. All right. So our case is that of a 47-year-old male who was referred to us on account of erectile dysfunction and headaches. The headaches were not associated with photosensitivity. There was no history of stress or depression. There's a positive history of loss in peripheral vision. Past medical history is not contributory, and patient is not on any medications. On examination, general examination, there was positive history. We found gynecomastia. HEENT examination was non-contributory. An examination of the neurologic system, there was decreased peripheral visual acuity. Pupils were reactive, and there were no issues with the extraocular movement. On genitourinary examination, patient had testicular atrophy. So with this presentation, with this clinical presentation, the history and the examination findings, what are the possible differential diagnoses? Anyone?
I think it can be a pituitary tumor.
Right.
First, a pituitary tumor. Secondly, a brain abscess.
Okay.
Thirdly, an aneurysm.
Thirdly, you said what?
An aneurysm.
Okay, aneurysm.
Yeah.
Right. Okay. Okay, anyone else? That was Ivan, yes?
No, it was Dr. Safari.
Okay. All right, anyone else? Please do try to introduce yourself again while you are trying to answer, because I can't see who is talking here. So any other ideas? Possible differential diagnosis. All right, so for differential diagnosis, usually the best to do is to always try to divide or categorize your differential diagnosis, right? So there are various things you could use to categorize it. You could either use vitamin or Tinkham-Bed. So you want to divide into trauma, infectious causes, neoplastic causes, vascular causes, or congenital causes, and things like that. So possible differential diagnosis would include, for neoplastic causes, like rightly answered, was a pituitary tumor, so a pituitary adenoma or a craniopharyngioma, meningioma, a pituitary metastasis. For inflammatory causes, you could have a lymphocytic hypophysis. Vascular causes, you could have an AVM of the cavernous sinus, an aneurysm, and like also rightly mentioned, brain abscess, cyst, or could be drugs. So based on like the history and this differential diagnosis, can we try to knock off some of this differential diagnosis before we move on to the next phase of management? Can anybody try to just kind of like say why some might not, like it might not be a craniopharyngioma or a meningioma, why it might be more likely pointed towards a particular diagnosis and not any of the ones listed here?
Right, from the presentation we had, the patient, if you look at the age of the patient, I mean the information gotten from the patient, the past medical history. You
Sorry,
see that,
please be speaking, Ivan.
Yeah, it's Ivan. Sorry, I forgot.
Oh, okay.
So we see that from the history of the patient, from the information that we have, we see that the patient is having some sort of hormonal disturbance from the presentation of the patient having gynecomastia and having some erectile dysfunction. Somehow we think of a hormonal problem, and from all these diagnoses, the cause that I see that is mainly affecting hormones, we have pituitary adenoma. I don't know if craniopharyngioma has to do with anything related to hormones. So for me, the main diagnosis I'm going to go in for is going to be a pituitary adenoma, and also we have the
go on.
And also we have the like the patient is having some sort of visual field issue. You know that the pituitary gland has to do with the optic chiasma. So I'm going to go in for the pituitary adenoma.
Right. Okay. Thank you. Anybody else?
Okay. I'm Tunde. How about okay?
All right. Hi, Tunde.
So I think I'll also rule out like inflammatory, like the lymphocytic hypophysitis, since there is no any past medical history that show maybe a recent infection or anything like that, and also there's no any past medical history that shows any pharmacy, like any drug like antidepressant and antipsychotics. So I think I will rule those out, and so people will just be left with the neoplastic and also, I'm not sure if vascular tumors like aneurysm, I don't know. I'm not sure if they actually have anything related at all to presenting with like those hormonal disorders, like Ivan has said.
All right. Okay. Thank you very much, Cindy. Anybody else? All right. So, great job, guys. Ivan, let's start with what you said about craniopharyngioma. Yeah, like you're saying, you don't know if it has anything to do with like hormonal disturbance and things like that. So craniopharyngioma is the most common is a very common childhood tumor, usually supratentorial, and it's usually located in the same place where you have a pituitary adenoma. So most often they usually have Yes, hormonal disturbance. So you can easily rule craniopharyngioma out because our patient is 45, thereabouts, 47, and craniopharyngiomas are usually located in children. So for lymphocytic hypophysis, like rightly said, Sunday, but the most important risk factor for a lymphocytic hypophysis is pregnancy. So usually seen in pregnancy or some sort of autoimmune condition, which our patient is not pregnant because he's male. And him being male, we can take out meningioma because meningioma is more commonly seen in females, and it usually has a more, it's slowly progressing. So it's going to take you a while. Although they didn't give us time, but it's going to take a while for you to see a meningioma. All right. So what initial imaging would we use for this patient? Anybody?
So okay, this Tunde again.
Yeah.
So
okay.
looking at like our setting in Africa, so you probably want to go for like a CT scan, which is more easily affordable by many. So
okay.
To answer this question, sorry, I'm Ivan. Just to try to bring some sort of addition to what the previous speaker just said. When you're doing a presentation here, you're trying to like give some sort of like what is standard, what is generally known. So history, we spoke about Africa, but we wish to. So we wish to have the standard. So the standard here is to go in for some neuroimaging, and the one of choice is going to be an MRI scan. This is because the MRI is going to give us some finer details on it's going to permit us to better appreciate the soft tissues in the brain. So we are going to go in for an MRI. It's going to be an MRI.
All right. Okay, so great work, guys. The standard anywhere in the world is going to be an MRI. Because it gives us a better view of the brain parenchyma, and from our differential diagnosis, it's something that has to do with brain parenchyma itself. All right, so this was the MRI of the patient. What can we see? I would really love if other people could participate aside Sunday and Ivan. So what can we see on this MRI? So you can try to tell us what MRI sequence this is and what you can see. Anyone?
I think in the image, in the first image, labeled A.
Okay.
Okay. It's the T1 ponderation.
Okay.
There we can see that there is a HIPAA signal on the pituitary.
I didn't get that.
What?
I didn't get what you said.
Okay. I was saying that we can see that the brain parenchyma is in isocyanol, and there is HIPAA signal on the optic chiasma, and there we see that it's referred to the pituitary gland there.
Okay. Okay. Thank you.
Okay.
Anything else?
We can see that the bones are in HIPAA signal.
Right.
I don't see nothing else.
Okay. All right. Great. Thank you very much. Anybody else? Okay. So the first image A is a T1 weighted image, and image B is a T2 weighted image. Image A is a T1 weighted image with contrast, and as we can see, this right here is the mass. As we can see that it's enhancing with contrast, and this is a T2 image showing the same thing without contrast. Yeah. Okay. So what can we see here? Anyone?
If I can say something else, the image, the two images are they're just coronal coronal sections, still of an MRI T1 weight, and it is yes, it is showing some. I mean, it's still showing the pituitary mass that you showed previously.
Yeah. Mm-hmm. Great. Yeah, and yeah, just to add to what you said, Ivan. So the image C is T1 with contrast, and image D is T1 without contrast. And as you can see, this one kind of like is brighter than the mass here. So that means the mass took up the contrast. And you know it's contrast because you can see some whitish here filling up the internal carotid arteries. All right. So this is still a T1 image with contrast, but this is a sagittal view. And you can see this mass that's lit up with contrast right here in the cella turcica. All right. Can anybody tell me what they see here?
I would say that this is, first of all, it's not an MRI scan.
Great.
Because yes, it's not an MRI scan, and it's a sagittal view. It's a sagittal section, and given that it's a CT scan, I think what they were trying to, what we are trying to look here is mainly the bony, the bone around the pituitary gland. So in terms of the investigation required, as we mentioned earlier, we have the MRI scan, which is the main investigation to identify and to better appreciate the tissues. But then we also have the CT scan that helps us to identify if there have been some sort of bone remodeling and if there have been some bone remodeling, which is usually associated with the pituitary adenoma.
Great. So great work, Ivan. So yeah, like rightly said, there's some bony remodeling, and then as you can see, the cella turcica is enlarged and is enlarging into the sphenoid sinus. This is sphenoid sinus, and cella turcica is kind of like enlarging into it. All right, so now that we've gone through the imaging, so what are possible differential diagnoses? We've looked at clinical presentation, looked at some imaging. So what would your mind be pointing towards right now? Anybody?
So based on like the previous differentials that we had, so I think like with this imaging, we can actually rule out a number of them, and we can actually think of the pituitary adenoma like a mass. I think a pituitary adenoma like a mass effect on the pituitary gland, something like that.
And just to add with more precision, we can say it's a pituitary macroadenoma.
Great. Okay. Yeah. So possible differential based on imaging. Yeah, it could be a pituitary carcinoma. Still a possible metastasis to the pituitary, hyperplasia of the pituitary gland. They could also be a meningioma, already ruled out craniopharyngioma, and a round cleft cyst. So further workup was done, and patient was found to have elevated level of prolactin, decreased LH and FSH, as well as testosterone. So what do we think possible diagnosis is now that we have this laboratory workup? So based on everything so far.
A prolactinoma.
Great. A prolactinoma. Thank you very much. Well, sorry, I didn't catch your name.
Ben Gadua.
Thanks. So yes, so possible diagnosis is a prolactinoma, and as Ivan rightly said, a pituitary macroadenoma, in bracket a prolactinoma, and we'll find out soon why it's a macroadenoma. All right, so usually for macroadenomas, when you do imaging, the imaging could either be iso-intense or hyper-intense on T1 weighted imaging. And we usually do like a CT scan, like we've shown, to kind of like define the bones of the stellar tossica and the spinous sinus. All right, so we're entering the second phase of our presentation, where I'll try to go through the current literature of pituitary macroadenoma, specifically prolactinoma. I'll be using this outline. So prolactinomas are a type of pituitary adenomas that express and secrete prolactin to variable degrees. They're almost invariably benign, and although they are benign, they are still clinically significant, and sometimes it can be very difficult to manage because these adenomas can sometimes be aggressive or locally invasive. They can compress vital structures. I'll show you the structures very soon. And sometimes it can be so malignant that it can disseminate within the central nervous system and outside the central nervous system. But this is usually very rare. So a brief anatomy of the pituitary gland, it's also called the hypophysis. I think some people like to call it as the central endocrine gland, because it kind of like secretes a number of hormones that control secretion of many other endocrine glands. It's divided into two parts, the anterior pituitary and the posterior pituitary. Anterior pituitary is also known as the adenohypophysis, which usually arises from the ractus pouch. The ractus pouch is an upward growth of the ectodermal roof of the stomatium. I'll show you what that is in a minute. And posterior pituitary arises from the downward growth of the floor of the dicephalon. I'll also show you what that is. So, this image, this is the dicephalon, this is the ractus pouch. So this upward growth is usually what finally gives off the anterior pituitary, also known as the adenohypophysis. The downward growth of the dicephalon is usually what gives the neurohypophysis, the posterior portion of the posterior pituitary gland. And right here is the optic chiasm. So just remember that the dicephalon is thalamus and the hypothalamus, basically. And yeah, so anterior pituitary from the ractus pouch and posterior pituitary from the dicephalon. Yeah, so this shows the anatomy of the pituitary gland. This pituitary gland right here, this is the anterior pituitary, posterior pituitary. It sits in the sella tossica, and sella tossica is like a bony structure that occupies a part of the sphenoid bone. The roof of the pituitary is formed by the diaphragm sella, and it's usually about less than 8 mm in size of a pea, and weighs about 0.5 grams. This is a picture showing a cavernous sinus coronal section that shows the pituitary gland. So right here is the pituitary gland. This blue thing all around is the cavernous sinus. There are some nerves that run in the cavernous sinus: oculomotor nerve, the trochlear nerve, the sixth nerve, the first and second part of the trigeminal, the first and second part of the cranial nerve 5. And here we have the carotid, internal carotid arteries. All right, so the anterior lobe of pituitary usually secretes FSH, LH, ACTH, prolactin, growth hormone, and posterior lobe secretes only 2 things, the ADH and oxytocin, and they all have different functions. So the etiology of pituitary adenomas is not really known. About 10 to 15% of all primary brain tumors are pituitary adenomas. 75% of these are usually secreting. About 40% of all pituitary adenomas are prolactinomas. The age prevalence usually varies from 2 to 80 years. Prolactinomas are more commonly seen in women with a peak incident that occurs during childbearing age. This slide shows the etiology of hyperprolactinoma. So there are many causes of increased prolactin secretion, aside you having a mass like a prolactinoma or a Rathke's cleft cyst or a craniopharyngioma or any of those other things. So you could have pharmacologic causes, especially patients who are using dopamine receptor antagonists or such as antipsychotics, patients who are on antiemetics such as metoclopramide, which is also a dopamine antagonist, and domperidone, patients who are on antidepressants like TCAs and SSRIs, so selective serotonin receptor inhibitors. So there are also some physiologic causes like pregnancy, nipple stimulation, sleep, exercise, and food ingestion. So just kind of like just have your mind all over the place when you see a patient with raised level of prolactin, that is not just only a pituitary mass. There are other causes, physiological, pharmacological, based on patient's clinical presentation, kind of like help narrow your thinking. So prolactinomas are usually classified according to size. The magic number is 10 millimeter in diameter. So when it's less than that, it's a microadenoma. When it's greater than 10 millimeter in diameter, it's a macroadenoma. And most prolactinomas are usually small. They're intracellular, which means they're just stuck within that bony structure, the cellular tussica, and they rarely increase in size. So like Ivan rightly said, our patient has a macroadenoma because it was greater than 10 mm in diameter. I know I did show you that, but usually after doing an MRI, with the soft copy, you can actually try to measure the sizes of some things in the brain, and then it's usually found to be greater than 10 mm diameter. So there's a hardy classification of prolactinoma based on radiology, and there's a classification from 0 to 4 and a grading from A to D. Classification from 0 to 4 kind of like just tells you if the pituitary gland appears normal or larger than it is, and if there's any invasion to things around. So that's whether it's invades locally or diffusely, as you have invasion in more than one place. And the grading tells and speaks more of presence or absence of supracellular or paracellular extension. So this image kind of like shows what I was talking about in the previous slide. So grade 0, the pituitary gland looks normal, nothing looks abnormal. Grade 1, you can see this little bump here. And grade 4 kind of like covers the entire pituitary gland. So the grade A to grade E, the second classification system, talks about it being either supracellular or paracellular. So supracellular, so this grade A is still confined within the cellar, and these are usually symmetrical. If there's presence or absence of supracellular extension, they're usually symmetrical. Paracellular extension kind of like covers the regions around the cellular tussica, doesn't go in the part of the cellular tussica. Pituitary adenomas are usually benign tumor. They appear to arise as a result of monoclonal expansion of a cell line of lactotrope cells of the adenohypophysis, probably due to somatic mutation. They've been linked to the AIP gene, and has been identified within some families and in children who have early onset of pituitary adenomas. So clinical presentation of pituitary adenomas usually depend on the endocrine effects. So the type of whatever endocrine symptoms you're seeing in the patient kind of like tell you if it is a prolactinoma, or if the hormone in question is growth hormone, or if the and other symptoms usually depend on space occupying effects such as superior expansion, lateral expansion, and inferior extension. I'll show you what all those in a minute. So this table just kind of like shows clinical presentations of patients with prolactinoma. In women, they can present with oligomenorrhea or amenorrhea, subfertility, decreased libido, acne, or osteopenia. So these are some of the endocrine symptoms that you can see in men. In men, you can see subfertility, reduced muscle mass. You can have loss of pubic hair. You can have gynecomastia like our patient, or galactorrhea. The mass effects usually occurs only with macroadenomas greater than 10 mm in diameter, so they can have headache, visual loss, seizures, or CSF fluid rhinorrhea. A very important mass effect to think about is the chiasmal syndromes. Remember in picture I showed earlier, the optic chiasm just is found just close to the pituitary adenoma. And this slide kind of like tells us that patients usually have different orientation of their optic chiasm. So you could either have a centrally located optic chiasm, a prefixed optic chiasm, or a postfixed optic chiasm. So what that means is that in a centrally located optic chiasm, the optic chiasm lies directly over the cella, just like this. So this is the cella turcica, this is the anterior portion of the cella turcica, and the distal portion of the cella turcica, and this is the optic chiasm, like lying directly over the cella. Now this is a prefixed chiasm. So in a prefixed chiasm, you have the optic chiasm lying more anterior. Yes, located in the tuberculum cella. So this is the tuberculum cella. And yeah, in a postfixed chiasm, the optic chiasm lies more posterior over the dorsum cella. This dorsum cella. So what that means is that if a patient has a macroadenoma that is going upward, and the patient has a prefixed chiasm, so it's going to compress more on the optic tract, not the optic chiasm, the optic tract, and the patient is going to have a homonymous hemianopsia. If it's going to impinge, if the patient has a normal chiasm, it's going to impinge on the optic, it's going to impinge on the optic chiasm, and the patient is going to have the bitemporal hemianopsia, which I'm sure most of us have heard of. All right, so for patients with prolactinomas or increased prolactin levels, so this is a good diagnostic algorithm you can use. So first of all, you want to check, take patients' blood samples and then just check for to see if there's actually increased level of prolactin. If there is, then you want to do an MRI. If the MRI shows a microadenoma without symptoms, then you can just follow up the patient. If there are symptoms present, then you want to treat. If the MRI shows a macroadenoma like our patient, then you want to treat. So this is a table, I don't know if it's clear, showing this is a table showing prolactin levels and how to interpret them. So first of all, first thing to note is this varies according to whatever lab you're using. So, but it's just like a general, these are just general values. So if you have prolactin level between 3 and 30 nanogram per ml, and mostly normal, and then this, if it's between 10 and 400, it's normal for someone who is pregnant. Between 2 and 20 is normal for a postmenopausal female. 3 and 30 is normal for a non-pregnant female. Between 25 and 150, that's moderate elevation, and it could either be seen in a prolactinoma, patients who have stop effect, I'll tell you what that is in a minute, or other causes of increased prolactin levels. And a level greater than 150, that's significant elevation, and that's most definitely going to be a prolactinoma. So stop effect is one of the things like I showed in previous slides, causes of moderate elevation of prolactin levels, and usually occurs due to an injury in the hypothalamus or the pituitary stalk, usually from surgery or any form of compression. Now this is because prolactin is the only pituitary hormone that has an inhibitory regulation. So the prolactin inhibitory factor, which is believed to be dopamine, and when you damage the hypothalamus or the pituitary stalk, you kind of like reduce levels of dopamine. Dopamine is supposed to normally inhibit prolactin production. And so once dopamine is lost, there's going to be a rise in prolactin levels. So it is one of the things that can cause a moderate elevation. But you have to take this, so you have to be careful. I mean, if you see somebody who has a prolactin level greater than 150 nanogram per ml, then it's most likely not moderate elevation. So, and it is, I mean, it kind of like shows that for people who have stop effect, I mean, you just kind of like have to follow these patients up. You can't use bromocriptine. Bromocriptine tries to, it's a dopamine agonist, and if you have removed the prolactin inhibitory factor, damage them, So I don't, bromocriptine won't work to treat patients with stop effects. So imaging for Lactinomas, usually brain MRI is the gold standard, and we do it with and without contrast. So what we usually do is something called the Pituitary protocol, where we take coronal cuts through the cella, showing the cavernous sinus and the optic chiasm. So for microadenomas, this regular Pituitary protocol might not pick it up. So you need to do something called a dynamic MRI. So a dynamic MRI tries to increase your chances of catching the tumor at a time when it enhances differentially from the gland. So what that means is that, so normally when you're giving contrast, usually gadolinium contrast, the pituitary gland usually enhances first before the pituitary tumor. So you kind of like have to take the MRI image at a time when you know that the pituitary gland has enhanced, and then next the pituitary tumor starts to enhance. And that way it will help you delineate the borders of the pituitary tumor. So it's usually, the dynamic MRI is usually taken during the temporal phase. So when you're doing imaging, there are some things that you're kind of like looking out for. First thing you're looking out for is to see if there's any invasion of the cavernous sinus. So so remember one of the things I mentioned, although it's not so common, is that macroadenomas, especially carcinomas, have a tendency to invade locally or diffusely. So one of the things they could invade is cavernous sinus, and there are a lot of important structures in cavernous sinus. So you kind of like want to check out for that when you're doing your imaging. Secondly, you want to check out for the location. Aside checking out for the location, you also want to look at what your patient's optic chiasm anatomy is, because this kind of like helps you during surgery. You also want to find out if there are involvement of the paracellular carotids. Remember in the earlier picture I showed that the internal carotids also located in the cavernous sinus. So you want to check out if there's any involvement of that as well. So for invasion of the cavernous sinus, there are three signs to look out for. First, you want to be sure that you kind of like ask yourself three questions. First question is there more than a 50% encirclement of the carotid artery? If this is there, then most likely you're not dealing with the cavernous with a pituitary adenoma, a Lactinoma, because it's mostly meningiomas that tend to constrict the carotid arteries. I mean, macroadenomas do not. Next thing you want to ask yourself to be sure that there's no cavernous sinus invasion is there a lateral displacement of the lateral wall of the cavernous sinus compared to the opposite side? Then you also want to ask yourself if there's any abnormal tissue, or does it look like there's more tissue on one side than the other side in the cavernous sinus as well. Other things to look out for on imaging is, so generally the neurohypophysis, that's the posterior part of the pituitary gland, usually has a hyperintensity on T1-weighted images. Right. So next you want to go into your treatment algorithm. So for treatment, the best thing first line is usually medical. So you want to give patients a dopamine agonist, right? And various agonists could be used, cavagoline or bromocriptine. And what you want to look out for is if the agonist is going to help control your patient's symptoms or not. If your patient seems intolerant to the particular dopamine agonist you've given, then you try to give another one. And if the patient is still not controlled, then you want to go into surgery. If the patient is controlled, then you want to repeat prolactin, repeat visual field, and do serial MRI images. Usually taper and stop when patient has been fully controlled, symptoms has resolved, and visual field has improved, and then you can follow up the patient. If patient relapse, then you want to start treatment all over again, and then see if you can control the patient symptoms. If patient's symptoms are not controlled, then you could use another dopamine agonist and see if it controls symptoms. If no control is achieved, then you want to go into surgery. If after surgery there's still no successful control of symptoms, then you want to think about radiotherapy. So like I said in the last slide, medical is usually the most, we usually start treatment with medical therapy. So you could use a dopamine agonist. The aim of dopamine agonist is to help normalize prolactin level, to restore reproductive function, and to decrease tumor size. Cabergoline is usually preferred because it has fewer side effects. It acts only on the D2 receptor, unlike bromocriptine, who is a D2 receptor agonist and D1 antagonist. Other things to consider is the use of gonadal steroid replacement therapy if the hormone levels remain low despite maximal treatment with dopamine agonist. So for surgery, surgery is usually reserved for patients who were unresponsive to medication or had side effects that were not tolerable. Surgeons usually question if to use endoscopic versus microscopic techniques. In the past, a lot of people use craniotomies. Radiation is rarely required, but sometimes it's used as an adjunct, especially if there's residual tumor or there's a lack of endocrinological response to surgery. And you could also do a stereotactic radiosurgery. So the question about endoscopic versus microscopic surgical techniques, a study done by Ikwuegbuenyi et al. He tried to, was a systematic review and a meta-analysis, and then they found out that there was endoscopic transperineal surgery was associated with a higher gross tumor removal and a lower incidence of septal perforation than in patients who had microscopic. So yeah, it's just kind of like something to think about. So surgical approaches could either be extracranial or transcranial. So transcranial could either be intradural, extradural, dural. Intradural approaches would include a subfrontal, peritoneal approach, a subtemporal approach. Extracranial approach usually includes our transsphenoidal or endoscopic endonasal approach. So I'm just going to try to, over the next few slides, go through the endoscopic approach to surgical technique used for the endoscopic approach for macroadenomas. There's going to be a bit of some neuroanatomy, so you can just try to follow me along. Yeah. So the first thing you want to do is, it's going to be like, patient is going to be under general anesthesia, so you want to get an oral and tracheal intubation done. You put an oral and gastric tube, and you try to secure it either on the lower lip or the chin. At this point, you also want to think about how you're going to control CSF leak post-op. So you want to think about either taking an abdominal fat graft harvest or a nasal septal flap harvest. So whatever your preference is, so you kind of like have to think about that at this point. So patients are usually positioned supine with the head of the bed up about 10 degrees for drainage. Positioning is usually done for every neurosurgical case, usually done to give the surgeon best access. And so for this endoscopic approach, we usually bring the ear of the patient toward the shoulder that is away from the surgeon. We use a Mayfield pin. It can be used just to ensure that you maintain this position. Patient's arms are usually docked. And now the spinous sign is usually assessed endoscopically through expansion of both sphenoid ostia behind the middle turbinates. Let me show you what that is. So this is the middle turbinates. This is the sphenoid sinus. This is the sphenoid ostia. So you're going through the nose. So it's an endoscopic endonasal. You go through the nose, go through the middle turbinates, and try to assess the sphenoid ostia to gain access into the sphenoid sinus, and then you can go for your cellular toxicology, which is this. All right, so then kind of like try to get more working channel by removing the posterior bony septum of the sphenoid sinus, as well as the rostrum of sphenoid sinus. So after getting access into the sphenoid sinus, you could see the cellar bulging into the sphenoid sinus with the planum sphenoidal above and the clivus below. This area is the planum sphenoidal, and then this is the clivus bone. So above, below. So the bone of the cellar floor is often thin and dehiscent, and then you usually try to remove either with a crescent longus or with the use of or try to create a defect in the cellular bone if a defect doesn't already exist with the use of a small high-speed irrigating drill or chisel. When the dura is exposed, you can now see the cavernous and intercavernous sinus. They're usually visibly blue. And then what you want to do is you also want to try to find where the carotid arteries are. It's usually done with a Doppler ultrasound. After doing that, you can now make a square of the dura, make a hole through the dura, and ensure that you avoid these structures, the cavernous and intercavernous sinuses, as well as the carotid arteries. Then you usually try to develop a plane between the tumor, the capsule of the tumor, and the normal pituitary gland, and then that aids in removing the tumor. Once you're done removing the tumor, the next thing is to try to reconstruct the cella using either a fat autograft, a septal bone. Don't think about using either a synthetic bone or dural substitutes, tissue adhesives, or nasal septal flap. Any of these could be used based on traditional, like whatever is traditionally done in the hospital, like whatever institution you're located at, or surgeon's preference, and all of that. Then you can remove your oral gastric tube, and you have to do some pharyngeal drainage before you extubation. Yeah. So there are some complications that that could arise. One of the things to do is you try to avoid these complications, especially if you're doing a transsphenoidal surgery. And an easy way to do this is to early identification of the carotid arteries, the optic nerve, and the optic chiasm. And you want to try to systematically examine while intra-op to ensure that with the use of your scope to ensure that you didn't damage any structures, and then you took out as much tumor as possible. For radiation therapy, sometimes usually done for recurrent anaplastic tumors. You don't go above 60 for a maximum dose. Patients are usually carefully monitored post-op, both to see if levels of prolactin have decreased and if there are any complications that came up, such as hypopituitarism, cortisol, or diabetes insipidus, or any of those. These are my references for further reading. Thank you. Any questions?
Thank you very much for the outstanding presentation and for the interesting case presentation that was done earlier. I don't know if anybody has a question.
All right. I think I would just like to know, I think from the case presentation, the patient has testicular atrophy. So I don't know what like how did that come about from the case? Like the pathophysiology behind that.
Thank you. Any other questions?
Okay, it seems there's no question again. Thanks so much, Dr. Chibuikem. Thanks for the wonderful presentation. And if there's no additional comment, I think we should call it a day today.
Before that, there was a question. Let me just answer that question. So, good question, Tunde. So prolactin, high levels of prolactin have been found to inhibit the gonadotropins, that's LH and FSH. So I'm sure if you remember carefully from the case presentation, the patient also had reduced levels of LH and FSH. And with reduced levels of LH and FSH, you're going to have reduced levels of testosterone, which kind of like you need that to have your testis functioning, right? So yeah, that's kind of like what caused the testicular atrophy. So prolactin levels, high levels of prolactin decreases normally causes inhibition of your gonadotropins, and then that would lead to low levels of testosterone. Yeah. Does that make sense?
Yes, thank you very much. Thank you very much for answering, and thank you for your presentation too.
Okay, thank you, Dr. Chibuikem, for the presentation, and thanks to everyone who were able to make the webinar today. We really appreciate, and we look forward to catching up with you guys next week. Okay, so we call it a day today. Thank you, everyone. Good night.